Good morning, everybody. Welcome to the June meeting of the Informed Prostate Cancer Support Group. I am Aaron Lamb. I'm your host today. While the pandemic may be on its last legs, we have not gotten word back from Sanford Burnham Prevost that we can return to the auditorium. We're definitely staying on top of it and anxious to return in person. We will definitely let you know once that happens, and we expect it's still going to be at least a couple of months away. Until then, we're still doing this Saturday morning, third Saturday of the month live streams, which we've gotten pretty good attendance with and good Q&A interaction with the audience, and we hope that you can continue to attend those. So you might see a little change to our list of IPCSG principles. I regret to inform you that our president, Lyle LaRoche, had an unfortunate accident recently and passed away. If you didn't see the write-up in this month's newsletter, it was a very nice write-up that Jean did about Lyle. We, of course, miss him, and we wish his family well, and glad that he's in a more peaceful place. Therefore, we've actually elected a new president. Bill Lewis is our new president. Congratulations to him. He'll continue to be doing some of the newsletter summaries. Jean Van Vliet is our director and treasurer. Steve Pendergast is our secretary and newsletter editor. Bill Manning is our director and videographer. Myself, now a director and still the meeting facilitator, and John Tassi is our webmaster. And of course, there is you, the 900 members of our support group. Everyone can be a volunteer, and you can be too. Our support to you is in the form of our website, ipcsg.org. There's a wealth of information there, links, of course, to this month's live streaming, links to prior descriptions of prior speakers, links to the newsletters, and the newsletters contain a wealth of information. They have excellent meeting summaries from the prior month's meeting and wonderful articles. This month I was just happening to read through some of the articles last night, and there's a great variety, everything from touching on today's subject of PSMA to talking about a recent cancer diagnosis. So it pertains to the entire spectrum of members. We do have the monthly video stream on the third Saturday of each month. And perhaps the most important support that we give to you is this hotline number. And this is especially useful for brand new, recently diagnosed or recently concerned men trying to get more information about prostate cancer treatment. This will connect you to one of our most experienced members who can help you figure out what questions to ask your doctor and help you make the right decision on what the best treatment is for you. We do need volunteers. We do need people to help recruit and schedule more speakers. We would like other men to share your experience. If you've recently had some of the new treatments or feel that your case is quite unique and or just would love to share your experience with other members so that they can benefit from your experience, please do let us know. We also need support in taking some of the hotline calls. And of course, you can just contact us if you'd like to volunteer, either through the website or, again, that hotline number. So our purpose is to help patients become their own best case manager through informing, networking, and caring. We are experienced participants, but no, we are not medical professionals. So any sharing by anyone of our group may not be substitute for your own medical counsel. We do need your support. We are a nonprofit organization and donations are tax deductible. We have no medical or religious affiliations. We still do have the same expenses despite doing streaming instead of live meetings. There's the costs of, for example, the Zoom meeting that you're attending right now, our website, advertising. We do still have a lot of expenses, and we do encourage you to help make a donation. You can do that via PayPal on our website or sending a check to the address below. That address is also available on the website. So for today's agenda, we have Dr. Jeremie Calais giving a talk on PSMA Theranostics. He's an assistant professor and director of clinical research of the clinical research program at Ahmanson Translational Theranostics Division in the Department of Molecular and Medical Pharmacology in UCLA. And with that, I'm going to turn it over to Dr. Calais.
Good morning, everyone. Thanks for joining. And I will try to share a little bit my experience on PSMA Theranostics, PSMA PET, that we do a lot at UCLA, but also give you a little bit of background of what is going on the landscape in the US. And as prostate cancer patients, you will probably have to use the PSMA technology, basically. So let me go to the slide. Before I start, here are my disclosures. I will pause a couple of seconds on that just to be systematic. And here we start. So first, a little bit of definition. Theranostic. What is theranostic? Theranostic is a concept of a single agent mixing both a therapeutic approach and a diagnostic approach for same molecular targets in the body. And with nuclear medicine is a perfect approach for theranostics. Nuclear medicine, you inject a radioactive drug that you know the target in the body. And because it is radioactive, you can detect it and follow it like a probe. So you inject it, you know where it's supposed to go on the target. And by using the radiation delivered locally to that target, you can do either imaging, if you do a PET-CT scan, for example, or you can also deliver radiation therapy locally to the cells that are expressing the target. That's what we call molecular radiotherapy or radioligand therapy or radionuclide therapy. We'll not give too much detail here, it's a bit overwhelming, but that's the principle. So on the same target, you can, depending on the radionuclide you use that has different physical properties, you can do either imaging or either therapy. And that's exactly what theranostics is. You see the disease and you treat the disease you see. And here we're talking about PSMA. That's the target, because this approach can be applied to many other types of cancer and other targets. But here, today, we're going to talk about prostate-specific membrane antigen. This target is highly overexpressed by the prostate cancer cells at very, very high level, whereas on the normal organ, it is only very little expressed. So you have a good ratio with the cancer cells that do express this target very specifically at high level, whereas it is at low level on normal organs. So for imaging, it's good, it's better, and for treatment, it's good because you treat specifically those cells that express the target. Here is how it looks like a PSMA PET scan in a normal patient. So you see that there is still, here we don't see any cancer. So you see that even in a patient without prostate cancer, you see some uptake in some normal organs. So you can see that in the kidney, you have a lot of expression. There is a lot of expression as well, a lot of uptake in the salivary gland. This will play a role, especially for the therapy side, but just that here, the biodistribution in the normal patients. But overall, there is very little background. Next slide. Here is how it looks like in a prostate cancer patient. This patient, 77-year-old, PSA initially at 7.1, Gleason was 9, so pretty aggressive. The bone scan was negative, and you can see all these black dots here. I'm going to put my pointer. All these black dots here, these are the prostate cancer lesion, basically. This region is the bladder because the tracer is excretory to the urine and goes into the bladder. But these black dots here are the prostate cancer lesion. In yellow, you can see the primary prostate cancer tumor in the prostate. In blue, you can see the lymph node metastasis. And in red, you can see bone metastasis. These were not seen on conventional imaging scans, CT and bone scan. So this is really a major advancement for prostate cancer imaging. We have started a whole clinical research program here at UCLA using PSMA PET scans. You can see here, we were one of the first sites in the US doing that. So we started in 2016, and now we have done, I think, even clinically, I would say, as of 2021, maybe 5,000 scans since the beginning. We applied for an approval with the FDA, which is pretty rare for a single academic site, such as UCSF and UCLA. There is no patent for gallium-68 PSMA 11, so there was no industry power behind it. So just an academic team, we got the FDA approved. For us, it was a huge achievement. We got visibility, and now we are able to offer that as not a research procedure, but as an FDA-approved technology. The insurance setup is on its way. Once you get FDA approval, the next step is to get insurance coverage, Medicare setup. It is still in the way. So it means that for now, patients, they still need to pay out of pocket the cost of the scan, but it is not via the research route, it is via a clinical route. It's just that the setup in Medicare, because it's still recent, is not done yet. We hope to get it done in the next, maybe next fall, something like that. Let's dive a little bit in more detail about the approved indications that we got with the FDA. You can see here, I highlighted, it is approved for men with suspected metastasis who are candidates for initial definitive therapy. Basically, initial staging, your surgeon, your medical oncologist, he wants to see if there is disease outside of the prostate before they can give you radiation therapy or surgery. So for that, let's look at an example. That's the same patient I showed initially. Here is his bone scan. Here is his CT scan. And as I showed earlier, you can see those prostate cancer lesions that show up. So here is just a color scale we use. We can choose whatever color we want. At the end, it's not the real color. It's just a signal with image that we can choose. But this was basically not seen on CT and bone scan. So these were negative by conventional imaging and positive by PSMA PET. Now, for initial staging, even if it's the best modality we have currently, it is not perfect. It's still limitations like with any medical imaging technique. You cannot go beyond the resolution of the camera and the detection. And you can see that when patients go to surgery and you try to compare you still miss some patients with micrometastatic disease in the pelvis. And it's just you cannot go beyond the resolution of PET. So people sometimes are disappointed when the scan is so-called negative or doesn't show anything. Some are relieved, some are disappointed because the scan shows nothing. But even a negative scan has valuable information in terms of prognosis. And even though it's the best imaging modality we currently have, it is not perfect, and the physician needs to know how to interpret the findings, knowing the limitations of the techniques. It's just that compared to before, it's a bit more sensitive now. Here's another example where you upstage patients, a little bit like I showed before. You see this bone lesion that is clearly visible on the PSMA PET scan. Was maybe here on the bone scan. Let me go back. Maybe here on the bone scan, but was not full. But it's clear. It's a clear cut on the PSMA PET scan. You can see here the primary tumor in the prostate as well. And sometimes it goes the other way around because it's more specific. You are able to downstage patients that are incorrectly staged as metastatic by bone scan. You can see here this rib uptake was suspicious for metastasis by the bone scan. This is still the bone scan here, but this is the PSMA PET scan, and you can see there is no uptake. So basically, the PSMA PET scan says there is no metastasis. The patient is switched from metastatic to non-metastatic. At the end, when you compare PSMA PET to bone scan, it is much more accurate, much more sensitive, much more specific. There is comparison where you see the PSMA PET scan on the right side, the bone scan on the left side, and basically see clearly an obvious difference in terms of resolution, and definition of the disease. Now, for primary staging in the prostate, it can play a role, but the reference standard remains MRI. The spatial resolution, you can see here how the resolution of the image is much more precise, much more refined. So MRI for the local staging within the prostate remains the modality of choice of reference. Now, in some cases, PSMA PET carries very high valuable information for the disease in the prostate, you can see here. And I think in the best of the world, you would combine both information. If you have to choose one, you choose just MRI. If you have to do the best, you will do both. And a little bit going further in that direction, there are some patients who very suspect that they have prostate cancer, but for some reason, the biopsies come back negative because the biopsy just missed the cancer spot within the prostate. It is not easy to get there. You see, it's like biopsy done usually intrarectally with an ultrasound device. And you have systematic template where you try to map with biopsy the whole prostate gland, but you still can miss many little spots. And sometimes MRI is difficult to interpret. So in these patients, PSMA PET can help as well by localizing with accuracy where to do the biopsy. And if you have a urologist that is comfortable to do fusion ultrasound and PSMA PET biopsy, such as that we have with Dr. Max at UCLA, we can target the areas we see on the PSMA PET scan with this biopsy. So far, it works very well. We have very good experience on that. And we are developing and expanding this technique further now. So this was the first approved indication. The second indication is patient for recurrent. They have been treated with radiation therapy, with surgery. Unfortunately, the disease is coming back for some patients. And in that case, PSMA PET can help localize where this PSA elevation is coming from. So with UCLA and UCSF, we combined our datasets of 600 patients, and with that, we went to the FDA, and this was the dataset that led to the FDA approval. I show here the detection rate, meaning when the scan is called positive, see some target lesion somewhere in the scan, and you can see that it is highly correlated with the PSA level. When the PSA is above 5, we are pretty sure to see something in any case. When the PSA is below 0.5, then the chance to see something on the scan gets pretty low, to the range of 30%. In Europe, in a dataset of 2,500 patients, we see basically the same findings. Up to 1, we almost see something at 100% of the case. But then under 1, it decreases, and when it's between 0.2 and 0.5, you're at 30-50% chance of seeing something. So again, people can be disappointed to have a negative stance when they have elevation of the PSA, but sometimes the disease is too small to be seen, and it's a bit too early. There is a trade-off because it is known that you have a better outcome when you treat earlier in cancer. So you want to treat earlier, you want to know where the disease is too small to be seen by a scan, so there is a trade-off between the two. This is the current state of the art, and we cannot go beyond these limitations as of now. When we look at the impact on management, it is pretty clear that across all the studies that have been published worldwide and even in practice, it has a major, massive impact on management when you compare with what the treatment would have been without the scan to what the treatment has been with the scan. It changed in at least 50% of the cases. So this has been shown. And when you compare PSMA PET scan to the already approved techniques, so the prior standard of care technique for localizing biochemical recurrence of prostate cancer in the US was Axumin PET scan. It's also a PET-CT technique. It's just that the tracer you inject is different. Here it is amino acid tracer. So basically it will go where the amino acid metabolism is increased, such as in prostate cancer. And so you can see here in that patient, these black dots here are areas with increased protein metabolism, cancer, and these were prostate cancer lesions. So that was the prior standard of care technique. But the level of increased metabolism It's just less at the level of PSMA target overexpression. So at the end, it is less sensitive than PSMA. And we compare in a study directly in the same patients, Axumin and PSMA. And you can see, for example, this lymph nodes was negative by Axumin, whereas it was clearly positive by PSMA. At the end, the detection rate in patients even at very low PSA level, below 2, was clearly superior for PSMA in comparison to Axumin. There is another case where you see that the uptake on the fluciclovine, so we still call this scan positive on the Axumin scan, it's just much less intense. So that's how we miss lesions. Long story short, PSMA PET is more sensitive than the Axumin scan. It's not that Axumin is not good. If you can do an Axumin scan, it's already very good. It's just that PSMA PET is now better. And so PSMA PET, as I already said, is now the most sensitive imaging technique we have for prostate cancer imaging. It is superior to conventional imaging. It is superior to choline PET, and it is superior to Axumin PET. So you detect better the disease at earlier stage. It is not perfect. Again, when you have 30 or 40% of detection rate, it means that in 60, 70%, you don't see anything on the scan. It's still negative. And at primary staging, again, I showed sensitivity of 40%. It means that in 60% of the case, the disease was also missed. So it's not perfect. But by showing still lesions at early stage, you can aim at treating them locally, focally, and hoping for a positive outcome that maybe the disease you see on that scan is maybe the whole disease that the patient has. And if you treat that, maybe the patient can be free of disease for quite some time. Here is an example of a patient who came at a PSA of 0.6. He already had surgery. He already had radiation therapy, salvage radiation therapy, but then PSA kept increasing. The PSMA PET scan showed a single bone rib metastasis. This was treated with radiation therapy only, no hormonal treatment. And then the PSA went to 0. And now after more than 2 years, PSA is still at 0. So in that patient, in that case, it worked pretty well. Probably that's more or less the whole disease burden of the patient. Another similar story where here it's a perirectal lymph node, very tiny lymph node. This would have never been called on CT. You can see intense uptake, a clear signal on the image here. The PSA at that time was 1.6. Patient had already surgery, already salvage radiation therapy, and PSA is 1.6. You see this lesion. We treated that lesion with radiation therapy only, no hormonal treatment. And now after 3 years, PSA is still at 0. So in some patients, it can work very well. Here is the patient himself. Let me see if it can work. Yes.
My name's Dave McOwen. For 25 years, I was a recording engineer at Capitol Records. In 2010, I was diagnosed with prostate cancer and subsequently had surgery. I underwent my first round of radiation therapy at that time. But then after 3 or 4 years, it once again began to creep up again. My interest was in reissue work, preparing older albums, older tapes for reissue on CD. As a mastering engineer, the worst thing you can do is go in heavy-handed with your digital tools and cause some kind of degradation to the audio in the sense of what gave the music its life, its excitement. If you do too much audio cleanup, you can suck the life right out of a recording. My doctor said that there's this new treatment that they would like to try on me.
PSMA PET-CT is a new imaging technique to inject a radioactive molecule that targets specifically a protein called PSMA, prostate-specific membrane antigen. A lot of radioactive tracer goes to the prostate cancer lesions and can be detected by the PET-CT scanner. It is like adding color to a black and white image.
When they reviewed the x-ray, they saw that there was one small little point in my abdomen that showed up as cancerous. But this time they were able to locate it very specifically, radiate with pinpoint accuracy so that no No other tissue was damaged anywhere else in my abdomen.
And 3 years after, he's still without any sign of active disease. So PSMA PET-CT really helped him to get a successful, individualized, targeted therapy.
It is remarkably similar to what I was doing to these audio tapes, removing just what needed to be removed and leaving everything else. My treatment at UCLA was, well, it was just incredible. I've had no side effects of the treatment. I'm able to live a completely normal life. I'm getting ready to retire, and I'm looking forward to a long and fun retirement. Fun retirement.
All right, and if you look at more patients that we did, you can see the PSA. That's the baseline level, and it goes down. When it goes down to 100%, it means it goes back to 0. And you can see that when you do PSMA PET targeted radiation therapy, you obtain very good PSA response, which suggests that you induce good treatment effect. Just to be clear, there are several PSMA PET agents. They have different names, different compounds. I will not go into detail here. You just have to know that they are all PSMA PETs and they all perform well. So, for example, there are some that are free of use, out of patent. That's the one we do at UCLA and UCSF because they are free of use. It's for academic sites like us. And some that are owned by industry companies, but they work also very well and they can go at a much wider scale and widespread use. And the recent one, PYL, has been approved. You can see the date pretty recently, May 27. So this will come very soon, very available to many sites. I think on the West Coast, they expect to have it available next fall. The reimbursement, I think, will be finally set up maybe early 2022 or late 2021. But it's on its way, and you will see them coming more and more and being much more available in the next couple of years for sure. At UCLA, you can schedule a PSMA PET scan. We have a pretty long waiting time. We are looking at 1 month to 6 weeks of waiting time, but we can schedule patients. We can sometimes accommodate some needs. So if you have, if your physician thinks you should do a PSMA PET scan, here is the contact info. I will share the slide, of course, with you, and then you can contact us to organize that. There is also web pages where you have all these details. And again, the reimbursement is not set up with Medicare and is not set up with insurance. There are some patients who did manage to have some coverage and reimbursement, but it's on a case-by-case basis. It's done by the patients themselves with their insurance. We, as of now, we're working with the insurance themselves and Medicare, but it is not set up, so we cannot guarantee that you will get reimbursed. So often the patient for now, they just pay out of pocket. It's around $3,300 per scan to cover the technical cost. We do no benefit on that. We still have some research trials that are open. And in these, of course, the scan is for free. So for patients who are willing to go into a clinical trial, it's a good opportunity to get a free scan. The two main ones we have open now is one for patients who will go to radiation therapy at initial staging. So they just have been diagnosed with prostate cancer. They have chosen to do radiation therapy. In that case, PSMA PET-CT can help. And we have this randomized trial where here you get 50-50 chance to get the scan or not. And then for us, it's a way to compare the patients who did get the scan and the patients who did not get the scan. But that's a 50-50 chance to get a free scan. And then there is another one for patients a little bit more advanced. They failed hormonal treatments and they are scheduled to start a new drug. It can be, what you know, maybe under Xtandi, under Zytiga, under or darolutamide or some drugs like that. If you know that you're starting that drug, and your physician intends to do that for you, we are interested to see the effect of the drug on the PSMA PET signal. So in that trial, patient gets several scans just at the initiation of the treatment and at 1 week and 3 months later. And again, of course, all the scans are for free. So that's another opportunity to get the scan, but that's also, of course, clinical research. So it's a bit different than the clinical pathway. Now let's switch to the therapy side. Again, I said that Theranostics is the combination of a therapeutic approach and a diagnostic approach. I talked about the diagnostic, the imaging part. Now, if we change the radionuclide that we use, for example, gallium-68 or fluorine-18 that are made for PET imaging, and you put another radionuclide such as lutetium-177 that deliver locally radiation that basically deliver high energy around where it has been emitted, that are basically killing cells around, then you can do treatments with that. It's called molecular radiotherapy. It's called radionuclide therapy. It's called radiopharmaceutical therapy, radioligand therapy. They're all the same. They all mean the same. And when we talk about prostate cancer, the main thing you will see and you will hear will be lutetium-177 PSMA. So that's what you have to keep in mind at the end. It's all that names may mean the same, and they mean lutetium-177 PSMA. I have also a nice video coming from our Australian colleagues, and I think it's very a nice explanation.
When injected into the body, the ligand attaches itself like a key fitting into a lock to a protein called prostate-specific membrane antigen, or PSMA for short, which is found on the surface of prostate cells. Up to 1,000 times more PSMA is found on prostate cancer cells, including prostate cancer that has spread to other parts of the body. The second stage of the process is treatment. This involves attaching a different radioactive atom to the ligand and injecting it into the patient's body. This new radioactive atom, lutetium-177, decays more slowly than gallium-68 and gives off a beta particle which kills the cancer. Doctors inject the lutetium ligand combination into the patient's body and it attaches itself to the cancer cells, where it begins to deliver the radiation. The beta particles only travel 1 millimeter, so they deliver high levels of radiation to the cancer cells, killing the cancer.
All right, I hope you were able to hear adequately the sound. And here is, for example, an example in a patient. PSA was 27. So here we're talking about much more advanced patients that I've shown before in the first part of the presentation, patient that we call metastatic castrate-resistant prostate cancer. So patients have a lot of metastases all around the body. They have failed multiple lines of therapies, hormonal treatment, then second line hormonal treatment, then chemotherapy. So they fail multiple lines of treatment. And then that's where lutetium PSMA so far has been tested and showed a very good improvement on patient outcome. So for example, in that patient, you see all the black dots here that correspond to lesions that disappear after 4 cycles. It's usually administered on per cycles every 6 to 8 weeks. And you see here the PSA decrease very nicely. Each yellow arrow is treatment cycle administration, and the blue arrows are the PET scan timing. So that's, of course, a very nice story. It is unfortunately not always like that, but I start by showing a very positive outcome here. One of the main strengths is that it is very well tolerated. You have fatigue, dry mouth, dry eyes, because you know that you have this uptake of the drug here that goes into the salivary gland there. So of course you have some side effects here. You can see it on the scan and you can guess it before. But overall it is, patients describe it, but they say it's okay, it's tolerable, I can still eat, they can deal with that at the end. So it is frequent, it is often reversible and moderate. There is some nausea and vomiting side effects on the day of the administration, but again, they go away pretty fast, nothing to compare with chemotherapy. There is a little bit of diarrhea, constipation, but usually on a moderate intensity. If patients have bone metastasis, of course, the treatment will go into the bone metastasis, will kill the bone metastasis, but also deliver some radiation therapy to the surrounding healthy bone marrow, producing the blood cells. So you can have a drop in the blood count. So of course, we monitor patients. We usually wait. If the patient has too severe blood count drop, then we wait that the bone marrow recovers before we administer the next cycle. We can, of course, give some transfusion if needed, but usually it's reversible and moderate. It never goes to severe blood count drops. If it does, it is unclear if it is by the prostate cancer metastases themselves or from the treatment. And again, compared to chemotherapy, we consider it very mild. You can have a flare effect, which is usually a good sign because it means the treatment went to the lesions, kills the cell, you have some inflammation, some edema, so this there's some pain, but after 5-7 days it goes away and it gives some relief to patient when patients have pain from the bone metastasis. And in some rare cases, you have kidney damage, but that's very rare. And it's usually in patients with already prior kidney disease. So this has to be known, but at the end, it's very rare. And if you have to compare to chemotherapy, it is much more well correlated. So that's one of the main strengths. This has been done for now, maybe let's say 5 to 6 years worldwide. It really started to be used maybe in 2015. They did it a lot in Germany and in Australia. You have a whole almost medical tourism around that because this was not available in the US before. So you have these types of website, Booking Health, where you can book your stay and be treated with that. And it had a pretty good success. And because it was very promising from all these patients treating in Europe and in Australia, Novartis came into the market. They were interested in that. They invested a lot. And now they are running this big clinical trial and they will go to the FDA approval for that. Again, I show here a positive results on the left side. You can see that all these lesions disappeared after 3 cycles. And unfortunately, it doesn't work in all patients. It is not a cure. It is not a miracle. It is just a new advanced drug that works very well, but it is not a cure. And in some patients, you can see massive progression, unfortunately, even with the 3 cycles of lutetium PSMA. Here again, other images where you see in red all the lesions that were segmented, that are different from the normal organs. You see the increasing of the number and the volume of these lesions after 3 cycles of lutetium PSMA. So pretty good response in these advanced patients. Whereas here you have again all the lesions in red here that increase in number and in volume after 3 cycles. This patient is not responding very well. So it doesn't work all the time. I would say at the end, we are more or less at a 50-50 good response rate, which is already very good for these patients with very advanced disease. Let me tell you about that study run by Novartis that is just out. ASCO is a very famous cancer community meeting that was held early in June, so 1 or 2 weeks ago. And it was a big thing. They released the results of this big study. It was a multi-center international study. They had like 100 sites across the world. They collected the data from 800 patients who were randomized into a control group and or the lutetium PSMA 617. All these patients had pretty advanced mCRPC disease, so metastatic, castrate resistant, who failed under hormonal treatment. and even more advanced after 1 or 2 rounds of chemotherapy. So very advanced patients, there's not a lot of good option at that stage. And so they were randomized into these 2 arms. And at the end, you can see the 2 curves here. Basically, the blue one is the one with patients treated by lutetium PSMA. The yellow one is the one with the control group. And you see a clear difference between the 2. For the whole cancer community, this was very exciting results. Basically, lutetium PSMA does much better. When you compare the response rates, these are each bar is a patient with the PSA level. So when you have something going down, it means the PSA is going down, which is good. And when you have a bar going up, it means the PSA is going up, which is not good. You have the 800 patients here. The 300 patients treated with lutetium PSMA. And all these ones, all these ones with a decline of the PSA by more than 50%, which is a commonly used threshold to say he's a good responder. This appears to be seen in 46% of the patient, which is, like I said, half of the patient will have a very good response to that treatment and will probably benefit significantly from it. And of course, it's not everyone, but it's already a lot and much better than anything else we have observed so far in that setting with very advanced disease. In the control group, you can see that this effect was only 7% of the cohort. So it is not yet FDA approved. It's on its way. With big companies like Novartis, they have the power and the way to move things forwards with the FDA. And they just, June 16, so June 16 was 3 days ago, there was this press release where they got the FDA breakthrough designation. So it means they will have a accelerated pathway for approval with the FDA. So we don't know exactly when it will be approved. That's my just personal estimate, late 2021, early 2022, it is coming. But that's really my personal opinion. I have no real information on that. So at UCLA, we already potentially we did a clinical trials with that. So we did that under research. But now, when you have a drug that will be approved, there is a program that is called Expanded Access Program by the FDA. So it means you can have access to non-approved drugs that that have an effect, and it's called the Expanded Access Protocol, Expanded Access Program. It's a way to bridge the gap between the clinical trial phase and the approval phase. And we are a participating site at UCLA. You see that it has been initiating in April or June this year. We are setting it up at UCLA now. So we hope to open very soon, maybe by the end of July. I think we'll be completely open and set up. And so we will be able to offer lutetium PSMA therapy at UCLA even before the final approval. And again, I hope that we get that approved by the end of July or maybe August. So for who that is, it is for advanced metastatic castrate-resistant prostate cancer patients who already failed. So you still have to fit this eligibility criteria to be able to receive that, because we need to stick with what we are allowed to do. And you have a checklist with inclusion and exclusion criteria that mimic basically the ones that were used for the trial as just showed you before. And so if you didn't have chemotherapy, you cannot get there. That's a question that comes often. You also need to do a PSMA PET scan before, because we need to make sure you don't have PSMA PET negative lesions, and we need to make sure that the target expression is sufficient to make sure that you will receive sufficient benefit from the PSMA targeted therapy. The logistic, it can be done up to 6 cycles, and usually the cycles are spaced at a 6 to 8 week time interval between each cycle. So I think that's it for today. I'm open to take any questions, and I want to thanks all my collaborators for this research program. The research, think you are always tricky, you always forget people, but that's of course a huge collaborative effort. So thank you very much for your attention.
Thank you, Doctor. That was a wonderful presentation. Quite a lot of new information there. I'm not as familiar with anything PSMA since this is so cutting edge. Go ahead, everybody, and please submit your questions. We already have a few questions on the Q&A. Doctor, are you able to see those questions?
Yes, I can see them. I think I'll go one by one.
Sounds good. And go ahead and you can also stop sharing your screen. Then everybody can see you a little bit more clearly.
Okay, sure. All right,
great.
You can see more clearly. Fred asks, is androgen deprivation therapy necessary as an adjunct to PSMA therapy? No, it is not. I think in the future, PSMA therapy will be moved at earlier stage. The more studies will be done, usually with new therapy like that, you start at very advanced stage patients, and then trials show efficacy. Then you try in the earlier space, and then again earlier space. So a little bit like Xtandi or Zytiga were moved from very advanced patients to now very early patients. I expect the same will happen in the next decade. But for now, it is for patients who failed already androgen deprivation therapy. Do you need to continue it while you're under? You need to continue it to get PSMA therapy? There is no real good answer to that. Just a global general rule is that medical oncologists, they tend to not discontinue ADT because they fear that the disease can explode, even though the patient is already progressing under ADT. They feel that if you remove that ADT, it will even go further up. So it depends a little bit of your medical oncology view on that. It's medical practice. There is no hard data to say it is better to do it with or without ADT. So at the end, I would say, is necessary? No. Is it better? We don't know yet. I hope it answered the question. You did compare the sensitivity Axumin versus PSMA 11. Yes, this is a clear-cut win for PSMA PET, and there is no debate. It is more sensitive. Now, Axumin is already a very good scan that performs much better than CT and bone scan, for example. Just that now this new one performs even better. But PSMA PET is also not perfect. It's just that, you go step by step. And at the end, if you have to rank them, you will have the true gold standard where you see all the disease. This is pathology, microscopic disease that you cannot see with image. Then you have PSMA PET scan, then you have Axumin, and then you have CT and bone scan, the old kind of techniques. So you did compare the sensitivity of Axumin versus PSMA. Yes, we did. PSMA PET is much better, especially at low PSA level, under 2, for example, in the early stage recurrence. When the patients are all very advanced, it may matter less because the disease is so big that any scan can take and can see it, basically. So this comparison accuracy is more relevant for patients with a small volume disease, early stage, because here you need more sensitivity. I hope that answered the question. Can you also compare PSMA 11 versus DCF-PYL? That's a very good question. Many people are asking that, especially the physicians. My final answer is they are all PSMA PETs and they are all good PSMA PET techniques. They perform very well both. So what matters is not to know which one you have, is to have one PSMA PET. And if it is PSMA 11, you can get access to, or it is DCF-PYL, go with whatever you can. They perform very similarly at the same level of detection. They both outperform Axumin, for example. So if you have the choice between PSMA 11 and Axumin, you take PSMA 11. If you have the choice between PYL and Axumin, you take PYL. It's also PSMA PET scan. So what matters is really the availability because they're very similar. They both target PSMA. They are both PSMA PET technique with very high sensitivity and specificity. Now, if you ask me as a true medical imaging radiologist, PYL may be slightly better in terms of resolution and definition of the disease when you read the scans, a bit more comfortable for the radiologist. but it doesn't change clinically your call of the final report. Patient metastasis would be probably metastasis with both scans. So I think at the end, there is no meaningful clinical impact. I hope that answers the question as well. Participant cost for the new lutetium trial. Very good question. So when it will be approved, I think, again, there will be a lot of time between the approval and the insurance setup. A company like Novartis, they will charge pretty high the cost for that. So I think the cost for the therapy at the end will be very high. But at some point, it will be covered by the insurance. This will take a little bit of time. I think by mid-2022, not before, we'll see some insurance coverage. So before, it is either done via research or at the patient cost. When we did it in research and the patient has to cover the cost, each cycle costed around $10,000, sorry, $10,000 per cycle. So if you do 4 cycles, around 40 to 50K. But this was done in a research setting. Now it may be a little bit different if you do it clinically, and I have no, I don't know with the costs they will come out. Regarding the expanded access program, the one that is bridging the gap that we are soon opening at UCLA, and I think other sites will participate as well. Here, Novartis is supposed to provide the drug for free. So they will provide lutetium PSMA for free. Because you still have some costs for the hospital fees and the administration. So the nursing fees, you know, the IV line, the saline, all the premedication, all the things that are around, you still have to cover the cost for that, which are not insignificant. For example, at UCLA, this would cost something like $1,500 per cycle. So if you do 4 to 6 cycles, you can end up with something with 7 to 8K at the end. But that's without the drug itself. It's just, you know, the surrounding procedures, administration fees and things like that. I hope it can answer the question, but that's a tricky one. How does the whole body dose of radiation, that's a very good question as well, in lutetium PSMA compared to IMRT that says 72 grams? So even, you know, the medical fields doesn't agree on that, and it's still the debate of many ongoing research. There is a huge difference between external beam radiation therapy and molecular radiotherapy. In external beam radiation therapy, you know how much energy you deliver. You press on the button, you say, I want that many photons with that energy, that quantity, and you know that that will be delivered to this area. It's a beam, and you can calculate that very easily. So the way you can estimate the gray, so the radiation dose delivery to the tissue, is straightforward. With molecular radiation therapy, you cannot do that because you don't know exactly how much radiation dose has been delivered locally. You inject it in the body, then you wait and see. And you know, many of the drugs can have been flushed out in the kidney. Many of the drugs can have been gone to some another place. You don't know at the end the exact amount of radiation dose in the tumor lesion. So that's one first point. The method to estimate that exists, but they are much more inaccurate than for external beam radiation therapy. Now, usually when you do lutetium PSMA, it's because patients have multiple lesions at multiple places, and therefore you cannot treat them with external beam radiation therapy because you would basically irradiate the whole body. You would basically kill the patients. What you need is specificity. You need to reach only the targets. And that's why molecular radiotherapy in these patients, where the disease is already too spread out, you cannot deliver focal radiation therapy. You know, you can do it if you have 1 or 2 lesions, but if you have 10 lesions, it's not possible. The patient would get too much radiation dose to the healthy surrounding tissue. So that's why molecular radiotherapy is a good approach for these patients, because you inject it and it will reach specifically the cancer cells that do express the target. We have some methods to estimate what is the radiation dose to these target lesions. Again, they are very inaccurate, but they are still, they give some kind of estimation. And it's very variable depending on the size of the lesion, depending on the level of expression of the target, and depending on the amount of ejected activity you give. It can range from 3-4 gray to 150 gray in some lesions that have very intense uptake. So at the end, I think you reach the tumor control locally is not as good as with external beam radiation therapy. You cannot reach that focal delivery dose that they reach with radiation therapy because you give less dose, basically. And but the advantage is that when you talk about 72 gray like that, this is just for the prostate. So you're giving 72 gray to one region only. You will not be able to give much more in other places. You know, the body could not take that. So here, one of the main strengths of lutetium PSMA therapy is that maybe you don't give 72 gray to the prostate itself only, but you are able to give, I don't know, maybe 30 gray to multiple lesions at the same time. So it's a different approach. This one is a tricky question. I hope I was able to give a little bit some hints of answer, but there is no clear-cut answer. Can you show us your family? No, they left. They left. It was this Saturday morning. They're at soccer. And are PSA levels the standard for measuring progress? Yes, yes, it is. PSA is for prostate cancer the most reliable tool we have. And early, of course, it has limitation. There is no perfection. But especially at early stage disease, when usually prostate cancer produce PSA at a kind of reliable level, you can rely on the PSA to estimate the volume of disease. If you have high PSA, the volume is high. It gets more tricky when in very advanced prostate cancer patients where that has received multiple lines of therapy, because the cancer differs. Sometimes the cancer evolves to not producing PSA anymore, whereas there's still cancer and they're still prostate cancer, but they don't behave differently, these cells. So then PSA is like less, let's say less robust to estimate the progression. But that's very more for advanced patients. But at the end, usually we read the scan in conjunction with the PSA level and the PSA kinetic. So yes, it is. PSA is actually an incredible and reliable test for medical purposes.
Thanks, Doctor. I actually have a couple of questions myself. One of your early slides, I'm not familiar with all of the abbreviations and terms, but one of your slides had SE, SPE, PPV, and NPV with a bunch of percentages. Can you explain what those refer to?
Sorry. You know, sometimes I extract slides from scientific conference. I put that for a patient community slide, and sometimes I forgot, you know, to adjust. It's clearly not appropriate.
Oh, it's quite all right.
NPV means negative predictive value. PPV means positive predictive value. So what is that? It is the number of positive stand, of true positive stand, among the number of positive stands. So it means when you see a positive stand, in how many cases it is actually really true, it is really disease.
Gotcha.
If you have 10% of PPV, it means that your scan is often positive, but it's often wrongly positive. If you have 95% of PPV, it means that when you see something on the scan, you're sure it is disease. And that's pretty much what we have with PSMA PET, so that's very reliable.
Yeah, excellent.
NPV is the negative predictive value. So it's the same thing the other way around. So when you have a negative scan, how often does it reflect the truth? How often the patient is actually negative? Sometimes it depends on the patient you're looking at. So very depending on the patient you're looking at, you will have different results. But for example, in early stage disease, the NPV is not perfect because you have microscopic lesions that you cannot see on the scan that are missed. So your scan is negative, but it doesn't mean necessarily that the patient is really negative. It just means that the scan was not able to pick it up because it was too small to be seen. So in that case, so NPV 100% would mean that each time you have a negative scan, there is no disease. but that's never the case. In fact, in medical imaging, it's not possible. But so usually when you have an NPV of 60 to 70%, it means that you miss 20 or 30% of the disease, even though you have a negative scan. I hope this helps a little bit. And then you have sensitivity and specificity. These ones are the other diagnostic accuracy parameters we use to usually compare medical imaging tests. And I don't know if we want to go there again in the definition here. I think it's already good with NPV and PPV.
Yeah, that certainly makes a lot of sense with those two terms. I think that somewhere I encountered I believe a fact that only 80% of prostate cancer cells, I guess, express, if that's the proper term, PSMA. Is that actually a fact? And I guess, is that part of the initial PSMA scan to filter out, where the PSMA treatment would actually not work?
Mm-hmm. Yes, it is true that it is not expressed at the same level intensity and across all the prostate cancer cells. Although why it is working so well, it is because it is highly overexpressed in most of the prostate cancer cells, especially at early disease. And so at early disease, I would say 95%, you don't miss. The one you miss are like hybrid prostate cancer, the one that have neuroendocrine differentiation, the one that have aggressive features. They're almost half prostate cancer. What becomes different, so that's for early disease when patients have not been treated yet or receive maybe 1 or 2 treatments only. When you give multiple treatment lines for unlucky patients, when the disease coming back and you give multiple lines, then the disease changes a lot. You induce selective pressure on some lesions, on some cells, and they tend to kind of have different behaviors, different patterns of expression, different phenotypes, and then you get heterogeneity of the disease. So in advanced patients, what happens is that you have still some prostate cancer cells that do express a lot, but you start to have a lot of new prostate cancer cells that sometimes don't express PSMA. That's true. So, but that happens more at advanced. The more you advance in the course, the more it gets heterogeneous and messy.
So if I understood you correctly, actually doing your trials on more advanced cases is actually, I guess, more difficult to achieve beneficial results, correct?
That is true. You're completely right. And that's why usually when you have, but on the ethical level, you always start by patient without other options initially. You have to prove an effect in these patients, even more, it's more difficult, before you can say in earlier patients, try this drug where there is no sign or proof or suggestion of efficacy. So in cancer, it works like that. You start early, you start late. Mm-hmm. But you're right, people have very good hope to see even further effects the more we remove the therapy at early stage. They really, that's what many people believe.
Excellent. Well, I think that's all the questions that we had. And I guess we're pretty close to your cutoff time too. So perfect timing here.
Yes.
I'd really like to thank you for the presentation that you gave. This was excellent. This is, I think, the first time that we've had a presentation on the actual PSA treatment itself. I know that I'm quite excited for this to be able to be used across the board for all patients. It's almost like the holy grail for things. And I know that a lot of our members are also quite interested when this will both be available for imaging as well as for treatment. So good luck with, I just saw that we had a couple more questions come in. Do you have just a moment to answer those?
Yeah, let's get this done. I got treated with intermediate localized prostate cancer 6 months ago. This will be monitored by the PSA. You should not do a scan for monitoring. You should do a scan only if you suspect that. And so I hope, because the treatment can have cured you, and I hope you will not need to do a scan. I hope for you don't need to come to us, and that's very possible.
So
the way that you trigger the PSMA scan by the PSA elevation, suspicion of recurrence. Okay.
Gotcha. That's what I was going to ask. And how about overseas to get going overseas to get earlier treatment?
Yeah, that's what people do.
And that's what Germany and Australia?
Yes, wealthy people. But that's what they do. Excellent. Yes, Australia and Germany are the main destinations for that. There might be others. Now I think it's starting really to have much more wider uptake, even in, I don't know, other countries. But my two recommendations are really Australia and Germany for sure. And that's an established pathway for seeking this treatment at early stage. Yes.
Excellent. Excellent.
Again, it's around always the 10K per cycle, something like that. But you have the hospitalization cost, the travel, and everything. So it does cost some money.
Well, again, thank you so much. Good luck with all of your research, and we're really looking forward to all of the approvals on this.
Yes, thank you very much for inviting me. And I will send the slides, and please feel free to reach out with any questions by email.
Wonderful. Thank you so much.
Thank you.
All
Have
right.
a good weekend. Bye-bye.
Take care. Bye-bye.